One of my first patients as an emergency doctor was Miss L, a woman with pelvic pain. She had been an activist in her home country and was jailed in a mixed-sex prison. She was gang raped daily for months. When she was released, she fled to the US and now didn't have a source of food or shelter and didn't know how to navigate the legal asylum process in a world so utterly foreign. My name is Theresa Cheng, and I'm a doctor, human rights attorney, and a 2020 NLC LA Fellow. As an emergency physician, I bear witness to variations of Miss L's story daily. When we think about the emergency department, or as we in medicine call it, the ED, the word opportunity doesn't immediately come to mind, but life-altering opportunity does exist. We are seeing an increasing number of patients with social emergencies arising from increasing social inequity. These social needs can be addressed with the new field of social emergency medicine and innovative community partnerships. The view that medicine should be used to promote social justice has a strong historical legacy. As early as 1848, public health advocate Rudolf Virchow challenged physicians to intervene at political levels, writing that, quote, "The physician is the natural attorney of the poor." The 1986 federal law EMTALA cemented emergency medicine's role at the intersection of medicine and daily life, offering services to all patients regardless of background. The problems born out of growing social inequity, climate change, and other such social determinants are often the direct or indirect reasons of ED visits. For example, we see asthmatic patients with difficulty breathing because of poor air quality, or the person hit by a car while walking along the road because there are no sidewalks. In the modern ED, homelessness, substance abuse, and violence are as pervasive as diabetes, high blood pressure, back pain. Emergency providers have become the primary providers for the neglected or the invisible, people who have fallen through the gaps of social policies and laws. The emergency department has become society's safety net, a place of last resort. One survey of patients identified socioeconomic challenges such as food insecurity as a top reason for seeking care in the ED. In fact, social determinants can contribute to upwards of 50% of health outcomes. Medical care, only 20%. We providers are poorly equipped to address these social emergencies. Traditional education has largely ignored this topic, and as an emergency physician, I am trained to identify and address medical emergencies, not social ones. Social emergency medicine changes this narrative. The ED is the place of greatest potential catchment, as this visit is some patients' only touch point into the healthcare or social system. This new approach to emergency medicine emphasizes that ED-based interventions can serve to better address patients' socioeconomic inequities while empowering providers as patient advocates. Financially, certain social emergency medicine programming has been shown to likely reduce healthcare costs and unnecessary ED returns by 40%. Meanwhile, the benefits for the individual are immeasurable. Say we identify and enroll a food insecure child into SNAP or food stamps while they're there in the ED for a sprained ankle. SNAP participation has been linked to fewer school absences, reduced homelessness, decreased healthcare costs, healthier pregnancies, and reduced nursing home needs. In other words, food security is associated with social, economic, and health gains throughout one's entire life. And this can be replicated for other social determinants of health: housing, health insurance, harm reduction. By ensuring that people's basic social needs are met, we promote human well-being and human dignity. Various forms of social emergency medicine already exist. Some EDs screen for homelessness. Meanwhile, medical legal partnerships where lawyers join healthcare teams can be found in 46 states. Emergency medicine trainees like me are growing social emergency medicine programs and protocols. So what happened to Miss L? I referred her to a wraparound program for torture victims and an immigration firm who took on her case pro bono. She's still waiting on the outcome of her asylum application. As emergency providers, we need to be creative in partnering with individuals like yourselves who are experts in social advocacy. By breaking down silos and inviting community partners into the emergency department, we have the opportunity to redefine emergency medicine together. Thank you.